When managing people with renal failure, there is a limitation of the amount of drugs that we have to use for those people. We know that all DPP-4 inhibitors are safe when used at the appropriate dose. So in the case of linagliptin, that's one dose right down to the baseline. In vildagliptin, we give 50 milligrams once daily instead of twice daily, and in sita and saxagliptin, we will half the dose and then quarter the dose as we get towards end-stage renal disease. With the GLP-1 receptor agonists, we know that liraglutide has some data right down to an eGFR of 30, and we're using that quite commonly in the UK. We know with the SGLT2 inhibitors, because of their mechanism of action, they just don't work in people with renal failure. So although there might be additional benefits, we choose not to use those agents. Sulfonylureas have never formally been tested, and renal failure does increase the risk of hypoglycemia, so we would tend to avoid those. The remaining treatment option would be insulin at a low dose. And remember, if we escalate insulin slowly, then we can achieve good glycemic control with a very low risk of hypoglycemia. Metformin has caused a considerable amount of controversy with renal impairment. We know that it is safe down to an eGFR of 60. When we drop from 60 to 30, we might require limiting the dose. There is a growing belief that metformin can be used safely for those at end-stage renal failure. However, the majority of guidelines do not support this use at the moment.